Today I am going to present a case on bilateral MCA occlusion. He is a 47-year-old male presented to us with history of sudden onset dysarthria and weakness of right upper limb. He had 2 episodes of transient dysarthria in past 3 days. Previously, he underwent PTCA for coronary artery disease 2 years back and was now on single antiplatelet and statin, and he is known hypertensive. When he came, his blood pressure was 140/90, pulse was 76 regular, his NIHS was 3/42 with dysarthria, right VMN facial palsy, and a right upper limb drift. MRI brain was done, which was showing left internal watershed territory infarctions. CT angiogram was done, which was showing bilateral MCA occlusion. We can see bilateral MCA occluded here. ACS are good, and narrowing is present in the terminal part of the ICA and also MCA. But puff of smoke appearance is not evident in this CT angiogram. So we have taken patient for DSA. This is left vertebral shoot, which is showing normal basilar and vertebrals with left PCA supporting anterior circulation. In the second picture, we can see in the late arterial phase, left MCA being supported by the PCA pile collaterals. MCA territory being supported by PCA pile collaterals. Right as ICA shoot showed, right MCA was occluded from the origin, and right MCA is being supplied by pile collaterals from ACA and from fetal PCA. So MCA territory is being supported by the pile collaterals from ACA and by fetal PCA. And left MCA and left ICA should show left M1 is occluded, left M1 is also occluded, and left MCA territory is being supplied by ACA and PCA pile collaterals. So both the sides MCA is occluded and the MCA territory is being supplied by ACA and PCA pile collaterals. Coming to careful evaluation of this DSA images, there were few irregularities in the left ICA and left ACA also. Except for this, there are no other major abnormalities in the vessels. There are few irregularities in the ICA and ACA. So impression was bilateral MCA occlusion and hemodynamic infarctions. And etiology, because of the prior history of CAD, we have thought atherosclerosis to be the etiology of bilateral occluded MCA. It may be a secondary. It was even puff of smoke appearance is not seen, but this may be a moya disease also, because even terminal ICA is mildly narrow, or it can be vasculitis. We have thought about three etiologies, but our main but we have thought atherosclerosis to be the most likely diagnosis. He was started on dual antiplatelets and high dose statins and was hydrated, and blood pressure was maintained at higher level. But patient developed one more episode of TIA with transient dysarthria and right side weakness. But this was transient and he became all right afterward. So coming to treatment options, what we can do for this patient? So there are basically 3 stages of hemodynamic impairment in patients with the terminal ICA or MCA occlusion. So stage 1 is drop of cerebral perfusion pressure due to lack of collaterals, which leads to cerebral vasodilatation. In this stage, cerebral blood flow may be normal and cerebral metabolic reserve may be normal, and the cerebral vascular reactivity, vascular reserve is reduced, and oxygen extraction fraction is normal. In stage 2 of hemodynamic impairment, there will be further drop of cerebral perfusion pressure, which leads to cerebral vasodilatation, and which also may get exhausted, and oxygen extraction fraction may increase. In the stage 3, there may be further drop of cerebral perfusion pressure, and the cerebral vascular reserve and oxygen extraction fraction may get exhausted, and finally there may be ischemia of cerebrum. So in these patients, STA-MCA bypass is a treatment option. So in which patients STA-MCA bypass will be useful? So this can be assessed by PET scan and SPECT scans. Increased oxygen extraction fraction on PET scan is predictive of recurrent ischemic stroke in symptomatic major cerebral artery occlusive diseases, and a diminished vascular reactivity in response to acetazolamide challenge test with reduced cerebral blood flow quantified by SPECT is also proven independent predictor of increased risk for stroke recurrence in patients with symptomatic major arterial occlusive diseases. So in selecting patients, PECT and SPECT may help us. And ECIC bypass surgery can restore the perfusion pressure in the area of a stage 2 hemodynamic ischemia, and has been expected to have preventive effect on stroke recurrence in patients with cerebral arterial occlusive diseases. So there were few studies on STA-MCA bypass. JET 1 and 2 trials are among them. JET study demonstrated for the first time preventive effect of ECIC bypass on stroke recurrence in selected patients. The patients who benefit with the ECIC bypass surgery are patients who are having cerebral blood flow less than 80% and cerebral vascular reserve less than 10%. So by with SPECT scan we can assess these things, and these patients may have benefit with the ECIC bypass surgery. But coming to COST trial, it failed to demonstrate benefit of ECIC bypass surgery over medical treatment for patients with symptomatic ICA occlusion and severe hemodynamic ischemia, which was evaluated by PET scan. The high incidence of early postoperative stroke prevented COST trial from proving effectiveness of ECIC bypass. But however, selecting patients with strict quantitative hemodynamic parameters, STA-MCA bypass may still be useful in preventing recurrent ischemic stroke in these patients. That's it, sir.
Yeah, now it's a time for discussion. The main learning points were one, the patient was presented with a very minor symptom, only dysarthria. Yes, and we were really surprised to see that on angiogram, both MCAs, M1s were totally occluded. And there was no puff of smoke appearance to suggest that whether it is a moya disease. Yes. So, and there were mild irregularities in the ACA, so which were suggestive probably of a chronic atherosclerotic process. Yes. There were no other features suggestive of a vasculitic process. The posterior circulation, there was no other features to suggest any medium or small vessel vasculitic changes. So the most likely etiology is atherosclerosis.
Yeah.
What was surprising and a big learning point was, with total M1 occluded on both sides, still the whole of MCA territory was adequately perfused through the collaterals from the posterior circulation, mainly through the fetal PCA as well as from the pile collaterals from the posterior cerebral artery. And also the collaterals from the ACA also was applied.
Yeah.
And another point which is against moya is the ACA is not at all involved. It was looking perfectly normal. So it was selectively involving the MCA territory. And no collaterals were seen arising from the occluded area to suggest a puff of smoke appearance.
Yeah.
And the infarcts were not in the cortical territory but in the lenticular striate territory.
Lenticular
So
striate.
probably,
Yes.
yeah, it's a deep infarct, mainly in the lenticular
Mhm.
striate territory. So probably the
Yes.
lenticular striate vessels which are arising from that area would have been affected because of this. And the cortex
Yes.
is
Yes.
adequately perfused by the pile collaterals.
Internal watershed territory infarctions.
So what is the main learning point is just because there is an M1 occlusion, we have to look into the collaterals mainly to decide before whether this patient doesn't need an immediate revascularization. He's
Yes,
unlikely
sir.
to, because I think now he's more than 2 months now on follow.
Yes, sir.
We adequately keep the BP marginally on a higher level to improve the hemodynamic perfusion. And the second main factor to look into is whether the patient has got a hemorheological factor like an elevated hemoglobin. If the hemoglobin is elevated, do a venesection and keep the hemoglobin at the ideal level, and then put them on dual antiplatelet medications. And
Yes.
very aggressive management of atherosclerosis like high dose atorvastatin. So if the patient is a smoker, stop smoking. So this is an
Yes.
interesting case. Thanks, Ranjit, for sharing this case. Okay.
Thank you.